Hi guys, this is Dr. Cole. We're gonna share today with you guys about digital on-X, the digital workflow for full mouth implant rehab. Today we supposed to have a moderator. I guess everybody already knew him well, Damasio. He encountered some minor technical issue, has been trying and figuring out what's supposed to do to, really get into the platform, but ended up not well. So I'm going to introduce myself. I'm going to moderate through my presentation as well as answer your question. So if you guys have any problem, just do not hesitate to put on in the platform, just address it down and they will collect all the answer at the end, just show it to me. But I'm going to solitary monitor on all of this and moderate all the procedure today. Okay, so as I mentioned, we are going to talk about on-X, the full mouth implant rehab. And on top of that, we're gonna share the digital workflow. So you can imagine how heavy this topic will be. It would be impossible for me to finish everything within the 1 hour time period. However, I would like to share with you guys more information as possible. So we might at the end, pass beyond the time frame slightly a little bit. So if you have anything like, really an urgent, you need to leave, please, you're welcome to just leave when the time is up. But I'm trying to cover as much as possible as I pre-discussed with Masio. And this is how we ended up, put more information for you guys. So again, any questions, just let me know at the end. Let's quickly dive into what we're going to talk about today. Quickly introduce myself. I graduated from dental school in Taiwan and finished my master degree, also the specialty degree in prosthodontics. Same year, I went to pursue further education in New York University, NYU, also in prostate department. And at the time, I really want to practice in New York, so I went into another formal 3-year training program for specialty prosthodontist in Columbia University. And I also graduated with my master degree. After I finished the degree, I was very lucky and fortunate that I was hired as a clinical assistant professor in both NYU and Columbia. But just, you will never know what the life would change. I ended up come back to Taiwan, practice now in Taiwan as the clinician, as well as teaching and practice as faculty in Taipei Medical University. So before we talked about like the real workflow and deliver a lot of information and knowledge to you guys, I would always love to start with the story from my very first patient, Mr. Kato. This Mr. Kato, this patient, he's actually the very first patient that I treat solitarily in Columbia University. And I really appreciate how he provided me this opportunity to share and learn with you guys after so many years after. It's been 10 years after I first treated him, 8 years after I first treated him. But I always love to start with him because that's how I started and how the progress that I learned and things that I encountered that actually drive me to shift into the digital workflow. So Mr. Kato, when he first walked into our clinic at Columbia University, you can see his big smile. He wasn't so shy about his teeth, regardless, it looks a little bit crazy. He is an artist, he's a meticulous sculptor and artist working on a lot of defined projects. So he wouldn't care much about his teeth, to be honest. He thinks that's fine as long as he can chew. The moment that he walked into my office, what really drive him to start to get his teeth restored, get his teeth fixed, is because of his grandchildren. He mentioned to me, his grandchildren will always point it at his teeth and laugh at him, say, "Oh my God, you look like a ghost. You look crazy. Like, you look like crazy. You look like a monster. What a monster." So he feels really disappointed. He wants to, really get this fixed to move forward, to build this relationship back. So in the moment that he walks in, he's pretty determined. He knows that he wants to get his smile back, regardless what the effort and money is. So when this type of patient, they walk in, they tell you, say, "Okay, I got money." The real issue will come down to you, right? Because you now need to provide like the best option ever to restoring not his smile back, but most importantly, the function. So as a resident, even though I have completed multiple specialty training program from Taiwan and also from NYU, the moment when I first received this type of cases, I always has problem as well. Like, I don't know what to get started. There's so many options that will pumping in your head. And there are so many problems on the teeth that you don't know whether you should save the teeth or not. So the thing that we will do as a specialty, and I'm pretty sure in your daily practice, will be you just take some photos and you will take some mold, right? And just like me, I will do the proper articulation. I will assess the vertebral dimension, some prosthodontic core value that later on I'm going to introduce to you guys. But I will articulate the case and I will analyze all the detail. Of course, we are going to double check upon what the condition of the existing teeth as well as the bone is. So now my problem, as I said, the patient will throw this mess to you and the problem will all on your shoulder because now your brain is like pumping up a lot. What should I do right now? There's so many options that I need to walk through. For all the teeth, whether I could save it or not, as a dentist, if there's a chance to save the teeth, of course, I wouldn't want to extract them all, especially considering his age and also maybe his systemic condition. And if it's for your own teeth, of course, you wouldn't be extract them so easily. So the first critical puzzle will be whether extract the teeth or not. And after we decide we actually could be able to extract all the teeth, we know that it's no longer salvageable. The second puzzle will come down to whether a treatment option for the patient would be better, it's removable or implant supported fixed dental prosthesis. There are logic and evidence based for all these options that you have to go through, and not only all on X, which is the implant supported fixed dental prosthesis. That's the only best solution for the patient. Once you decided you're going to do this implant full mouth rehab with the fixed solution, the final puzzle will be, and the final challenge will be, what type of prosthetic design you should provide the patient, whether it's a traditional hybrid, as I just showed at the bottom left side, whether we should section into pieces or we should use the bottom right, which is a zirconia, or if there's any other design that's providing patient the proper biology, aesthetics, function, as well as durability. Those are the parameters that we are looking into and we need to assess in our brand, providing the patient the optimal treatment options that's suitable for their customized condition. So actually, what's the next? Before I start to talk to the patient, explaining all these details, I deliberately need to sit down and analyze all this background data to come up with a proper plan that I'm responsible to the patient's future. So here come down to what the problem from the conventional dentistry. So I would like to start with talking about the problem of conventional dentistry, and that is the main reason why the industry has been pushing us, the dental field, forward to the digital world. If there's not any problem for what we have been doing for the past maybe like 200 years, why should we go into digital? Is it just only for marketing, or there's a solid reason for that? So let's first quickly look at what the problem is from the conventional workflow. Just like my case, Mr. Kato, I collect all the data. I have been, checked upon clinically and also recording through radiograph, through photos, or through the models. Now the question comes down to the second stage. I look upon all this information through my eyes. Maybe it's through, the photos that I recorded, but now I need to digest, and what's more important, transfer all this information to the third party, which is my technician, my interdisciplinary doctors, about all the information that I want them to treat further. So oftentimes we're talking, through the phone or even through social media, that advising our technician or our doctors. Whatever we saw is very difficult to pass along properly. So you wouldn't be very certain whether what they are thinking is exactly reflecting what you're thinking. And that is the problem of communication, and that is the pitfall of conventional workflow. So basically, whatever you saw through the eyes or whatever they saw through the radiograph, you can only, use your imagination or point it at some spots that you potentially in the future, you can create the teeth and create the implant position. So the problem, as you saw at the right aisle just appear, the teeth position that we are trying to restore, reestablish in the future from the technician that they created it. Frequently, it's not clinical usable. It's not adapted to 100% to the clinical scenario, or I should say it's very difficult for us to trial or to see whether the teeth are designed correlated to patient's face or correlated to patient's bone condition. The second part is also the problem when you place the implant, when you do the freehand implant placement. You always imagine where the future teeth position is, and you potentially watch through, you were observing through the cone beam CT. But whatever you saw in your hand while you're drilling, your brain is literally working a lot by imagining, both the implant position, the bone condition, as well as the future restorative position, which is difficult. It's very hard, and that's why we lost control of the case frequently. So, however, the problem that's generated from the conventional workflow, you can see in this slides, starting from the data acquisition, the data collection, the composition shrinkage from the impression material as well as the stone. Of course, for years we tried to compensate and accommodate this shrinkage, but there's an error. When we have this data that's in monocolor, it's difficult for us to fully pass along to our technician, lab technician. So frequently, whatever design that they come up with, it's hard to 100% execute it or reflecting or re-execute it on our patient. So the wax up you can see on the slides, frequently it will become just a typodon. So I will always laugh around, and joke around, say, sometimes if you don't provide enough information or your technician is not careful enough to adapt all this information to design the teeth or to establish the teeth, it's literally useless or wasteless for you to pay so much money and then spend so much time to do the diagnostic wax up. You can just show them, or you can just use a standard typodon to demonstrate everything, because you don't apply any of the patient's data to your clinical scenario in the future. The third part of the problem is manufacturing. The conventional manufacturing, for instance, the heat processing for dentures, the casting for the metal ceramic design, there's shrinkage and there's error, and there's so much factors that need to be controlled by human beings, which is the part that the error or the discrepancy that's from. That being said, it's hard to provide the premium quality of the treatment with the problem that the conventional workflow has been carried. Sometimes there's a lot of human factors that's been introduced in the conventional workflow. So if you're walked into the clinic with a good mood, or your technician had a fight with their wife, starting, from the last night, they're in bad mood today. It literally significantly affects the quality of the treatment, which is the thing that we probably don't want to encounter in this modern medical field. So what the quality and what the premium quality of the treatment is supposed to compose these couple factors. First, we want to provide a treatment that could possibly increase the biology, which is the cleansability that built into the factor. The patient could be able to maintain this restoration in the future. Number two is of course function. Nobody doesn't want to chew, only want to look nice. And number three is the aesthetics. Nowadays in this modern dental field, because of how heavily social media has been played a significant role in our daily life, we always need to respect the aesthetics. That's why the data collection needs to reconsider a lot of the patient's problem. As the fourth, we need to provide the treatment that carries the durability, which is not only used for a day, a month, or a year. We want it to be sustainable for more than 5 or 10 years. A premium quality of the treatment can potentially provide decreasing the following factors, which is saving us time, saving us some potential cost, and most importantly, save us some headaches. We're no longer suffering from, the miscommunication with our technician or with our partners, because the digital dentistry will provide some value that later on I'm going to introduce you guys. So the quality service of the treatment, as I keep on mentioning, the American College of Prosthodontic Society has been introduced for full mouth implant rehab, is we want to provide this type of treatment that is actually all splendid because of mechanics, because of providing proper occlusion, because of providing the proper cross arch stability. And they want it to be screw-tan because of the retrievability, which is the longevity, and also for the cleansability. And of course, it looks nice. So that is the main goal, and that is the main reason why we were relying nowadays the digital dentistry that can provide us further improvement. Substituting what we saw, we nowadays can be able to use the scanner, which reflecting three-dimensional of the geometry of your teeth, as well as the bone structure or soft tissue structure, that also carrying on the color. And of course, we have the cone beam CT, but the most crucial thing I consider what the digital workflow that provides us is actually the software. Now we could be able to really discuss on the same platform by looking at the real design on the software. So we're no longer talking about, this mesial corner, this line angle up in the air with the imagination. Instead, we're looking at the software, looking at how we actually designed it on the real visual platform, that we know how we are going to, in the future, design our implant position is related to the tooth, and then place the implant precisely with the monitor. Or even more importantly, the manufacturing procedure, we can be able to proceed reducing the human error using the milling machine. And of course, nowadays it has been improved a lot, the printer. So what substitute the conventional workflow is seriously trying to make our life easier and trying to provide more benefit to our patient. That's starting from data collection. We use the photograph capturing image, and then you design it on the software. You can be able to discuss and reviewing all the sequence, as well as discussing with your patient, and also the manufacturing procedure with the control. That being said, looking back of what I would like to provide you guys, just as I mentioned, what happened to Mr. Kato. We have this digital tool to help us to start with the planning, start with how we are going to approach to this patient. But most importantly, it is as a doctor, our brand, how we should walk there, whether extract the teeth or not, whether the implant on egg, that's the only solution or not, whether it's the better option for the patient or not. So in order to give everybody, and also myself, a template to follow, or I should say a work list, a checklist, I created this algorithm that everybody can, somewhat follow this. You probably would have missed so much at the end, providing the treatment, as I mentioned, that is the premium quality of the treatment for the patient. So in order to reach the end goal that is highly potentially correlated to your clinical scenario, the first step is whether we extract the teeth or not. And with that, we will check upon each of the factors, whether endodontically, periodontically, prosthodontically, this tooth can be saved or not. And as a total, we will check upon strategically whether the tooth need to be extracted for the prosthetic convenience or not. So after we decided, okay, we're going to extract all the teeth because of all this perspective based upon science, based upon the textbook principles, before we start to design the teeth that looks perfect, looks nice, you have this perfect smile and the perfect curved smile, you have to always respect the physiology, which is the condition of the patient. That being said, it's not only the implant or the fixed solution that is actually is one of the most accommodable solution for the patient. You actually need to check upon these critical prosthodontic core value to reestablish the teeth at the position that's physiologically your patient can be tolerating. What that means is you basically need to reassess the vertical dimension and see whether you have space or not. Because sometimes, all on X, it requires a lot of restorative space, more than from the platform to the incisal edge is like 11 to 40 millimeters. It's not all the patients can have the space to accommodate this type of treatment. So you have to first incorporate in your future plan, which is a fixed or removable or implant solution, to adapt to what the patient's bodily can be tolerated, physiologically can be tolerated or not. Once you're determined with a certain type of the treatment, then you consider whether that's biological, aesthetically, mechanically, and hygienically designable for the patient to starting to really establish the tooth at their proper position. You will decide the incisal edge and then the plan, of course, and the proper lip support at the end with the proper proportion. So once the first three critical steps has been done, you know where your future teeth are going to be. Then it comes to the second part, which is the surgical part. And that is the time for you to be able to really start to think about surgery. Nowadays, it's so important for us to think prosthetically prior to the surgical procedure, because at the end, what the patient really needs is not a parallel implant. They want the teeth to be able to restore, to function, to chew, to smile, to use for a longer term period. So it is so crucial, just like you're fabricating your complete denture when the patient don't have anything or everything's falling apart. You have to put back where the teeth are looking nice and adapting to their body, their vertical dimension and center relationship, their joint position. Then you start to think about your implant, where the implant is going to be, whether you should first graft it or not. So the surgical procedure is always after the prosthetic procedure. You will now analyze the bone condition following by your teeth position. Then you will be able to simulate where this implant position is. So you will now be able to know whether you should graft it or not, whether the timing, which is the loading protocol, could be executed for immediate load or not, and that's the critical part for all on X, because we always, if it's possible, we want to put an implant in, and meanwhile provided a screw retained full arch implant prosthesis as for provisional for the period of time for healing for those implants. So after you complete the procedure for surgical part, you know your implant distribution, the numbers of it, the positions of it, and also whether they engage enough with your native bone by simulation. Then you could be able to really treatment plan for your provisional. If you can be able to engage enough of your implant, then of course you can provide a fixed provisional restoration that's a full arch cross arch splinted full arch provisional. If the patient if the implant doesn't seem through the simulation that has enough engagement with the native bone, maybe you need to do the removable. But always remember, when you provide a removable interim or removable provisional restoration for the patient, the bone, if the patient, the surgery will in conjunction with extensive grafting procedure, then highly chances it will fail. So those are the sequence that you need to go through this step by step. First, establish teeth. Then you incorporate your bone condition to do the simulation. And at the end, you select a proper provisional to provide to your patient that is benefit for your surgical procedure for implant heal and for bone to grow. And that has, of course, the analog workflow, but today we are going to introduce mostly the digital workflow. So after we complete through this logical template, we have decided, okay, we can provide this patient, okay, the fitting dentition, we need to remove all the teeth, and the implant can be planted in and providing with the implant supported fixed provisional that has a cross arch, the roundhouse splinting. Today, I am going to introduce you the feature of this lecture, which is the digital workflow, the full digital workflow for All-on-X for immediate low procedure that has the highest control of the cases, reducing your headaches and improving the longevity. So here is the workflow. And there are a couple features I am going to talk about later, but I'm going to briefly address it over here. Is the workflow, as you can see, starting from left to the right. I'm going to go into each of the specific parameters in depth, but the highlight of this workflow is number one, we are going to place the implant incorporating an dynamic approach to really being able to control the placement of the implant and the position of the implant. And number two is, of course, we're featuring using the BEGO implant parts, which I'm going to talk about a little bit more in depth. Why would I select this type of implant parts, or I would select this brand particularly. Okay, so first, data collection. As I kept addressing, it is so crucial for us to do the data collection properly and walk through all the parameters. As I said, assessing through each of the tooth, the periodontal condition, endodontic condition, prosthodontic condition, whether this tooth is salvageable or not, whether this tooth can be a abutment or not, or it's just staying in your mouth and cannot provide any type of function. Once you walk through your list, you make sure that this teeth is no longer suitable to stay in the mouth, not being able to provide any type of function, then we will remove them. Once we start to come up with the solution of removing all the teeth, we will of course incorporate it in removable or fixed solutions. The fixed solution, as I said, it will of course has to be accommodate with the implant. So we will start to think about whether the patient has enough space. So we need to establish the tooth back to adapting to the patient's physiological and aesthetic condition. So this is the first part of what we start the data collection part. And the second part is once we assess everything, we have the list of where we should put the teeth back. Then we will, of course, use the software to start to build this tooth in. After arranging all the teeth, then later on, I'm going to introduce you clinically. We will do a printout prototype to be able to try into the patient's mouth to verify the accuracy of our design. And following by the sequence, once we establish the tooth, just as what you saw at the top left corner of the red part, you will see a tooth-like full arch shape in pink. We will then superimpose the teeth position along with the bone condition so that you will be able to really design your implant position, angulation, and depth, and the numbers of the implant and distribution of the implant along with the future teeth design as well as the bone condition. So as you can see in the middle of the bottom, you will see a pink tooth cross-section view, and you will see an implant simulation in yellow. This is how we do in the modern dental field. We will plant the implant in along, of course, with the bone, but most importantly, along with the tooth position that in the future, we know it needs to be screw retain. As remember, as I mentioned, the premium quality of the treatment, it has to be screw retain, and in the future it has to be split altogether. So all of this, we will be able to plan on the software, and you could also have the freedom to talk to your interdisciplinary team members along with this visual treatment plan. So carry on. After you finish the treatment plan, you then place the implant in, following by your plan, right? Otherwise, the plan is just up in the air. So the way how we do it is we use the dynamic approach. The navigation machine will guide us precisely placing implant in, followed by our plan. And of course, we use the BEGO Implant System, the transmucosal abutment that will provide us some benefit in the future to splint all the implant together and also maintaining a screw retain implant prosthesis. So the same plan will also be utilized to prepare a shell for us to execute the immediate load. And the immediate load is screw retain design. So the shell, the full arch implant provisional restoration will be prepared, leaving the corresponding holes that's along with our implant plan. So basically, we will place the implant in precisely, and we will also prepare a provisional restoration that leaving the corresponding holes for us to do this immediate provisional loading procedure. So this is this part. It comes to this part. After we design it, we use the software to design this corresponding holes along with your implant position. Then we will have the machine to mill out a full arch implant, a full arch provisional shell that leave the corresponding holes. So for the immediate loading procedures, I will again talk about the BEGO transmucosal abutment as well as the temporary titanium temporary cylinders. For the last, the impression after 6 months of the healing, I will talk briefly about what we are doing right now and what the future could be that for full arch implant impression, achieving a screw retain implant prosthesis with passive fit. So this will be the skin body that nowadays I am experimenting out for the full arch skin. Okay, so let's start with the first part. So the data collection, I was just talking in the air, as I said, using imagination is difficult, so I'm going to show you visually. Look at this patient. This is the first patient that I actually used in Taiwan when I first came back, utilizing the BEGO implant system. So on this patient, this happened to be a very close friend of mine. He's also a dentist. He isn't so confident in providing his dad this complicated treatment, so he referred that to me. As you can see, we go through a list, we make sure we finalize we're not going to save any of the teeth. The patient used to wear this like icky, valplast for such a long time, jeopardizing his nutrition status. Actually, he's malnutrition. He couldn't be able to talk properly, and this thing is like always dirty and stinks. It jeopardized his social ability as well. So first, we start our data collection. We do our scan. We we do our scan. We do the home beam CT. We take the bone scan, and also we will take some photos to establish where the teeth are correlated to what the patient's aesthetic parameters. But separately, as I kept mentioning, what's more important is actually the prosthodontic core value, which is assessing vertical dimension and assessing whether the patient's current bite, which is restoring whether at the habitual bite or CR. Most of the cases, if in dentition, of course, we're not going to adapt the current bite we would like to establish into the bite, the interocclusal record, the situation that's healthy for your joint. It's repeatable for the patient in the future for a better function. So the photos that we collected, its benefit for the aesthetics in the future. And nowadays with the assist of technology, you can see the design that it actually reflects where the future teeth is correlated to his face. Oh, also, I would like to address here by not decoding the patient. This patient, he loves his teeth so much that he always like requested me strongly, like, do not decode me, like, don't cover my eyes. I would love to show my condition to the world, like how the improvement is. So guys, I have requested, I have the waiver, like he would love me to use this photo without decoding him for the entire whole presentation. So basically, this is what you guys have been doing, I'm pretty sure, lately, the digital smile design using the software. So however we modify along with the photos, it will reflect on the digital design of the digital diagnostic wax up. So this is the teeth wax up that eventually will reflect not only the occlusion that you can see on this red dots at the right side, but as well as the aesthetics. So we will then print out this prototype, as I said, to try in the patient's mouth to re-verify the aesthetics of function and also the occlusion. So this is how the prototype is. Once we approve that, then we're gonna use this diagnostic wax up to prepare for the next step, which is the most important part, designing where our future implant is going to be. In this modern field, the digital equipment will never be enough for us. So the facial scan nowadays become another additional tool that pushes us to go one extra mile. The facial scan is not only carrying the face three-dimensionally for us to design the teeth to look better, it actually could provide us, most importantly, the last missing puzzle, which is our condyle parameters, the path, how we chew. So in this execution, you can see just like the conventional, just under the conventional field, how we guide the patient, capturing their condyle parameters, how the condyle rotates and slide, the translate down. It captures this path just like conventional pantograph that we utilize in our fully adjustable articulator. It's the same thing for the software and also for the virtual articulator. You can either select to use, if you can see the right top corner, the standard setting of your articulator to not, again, like I repeat over and over again, to restore not only aesthetics, not only to smile, to look nice, but most importantly, achieving the occlusion that we want to provide this patient along with the design, the prosthetic design. For instance, for implant supported fixed dental prosthesis, we would love to provide the patient according to the literature and all the scientific evidence. It's either anterior guidance mutual protective occlusion or unilateral growth function. So basically, we go one extra mile further. The digital tool nowadays can also benefit us a lot. If you can see over the right, this is how we built in the customized condyle parameters. We now are no longer only adapt to the standard parameters that could highly potentially in the future not correlated to patient's clinical scenario. We want to create anterior guidance, but at the end, there's interference at the back. So this is how we design it, how we capture the data. And when the design, it literally rebuilt not only the teeth to look nice, or that not only the teeth to somewhat look okay at their position and providing the even contact for function, but you literally reduce our chair time for adjusting for occlusion, achieving the occlusal scheme that we want, which is here, I will want it to be the anterior guidance, the mutual protective occlusion. So the digital wax up at the end, it will look like that. Once I verify with the technician that's the aesthetics and function, the occlusion that I desire, then I will approve that wax up. Moving along, this now comes into the second part, which is, as I said, we want to synchronize, we want to superimpose the design with the bone so that we can start to plan where the implant is going to be. So at this point, basically, you know the future teeth is going to be. It's just like you know your destination, you know, you foresee your destination already. And it is important for you to really first know your destination is, then utilize this type of navigation machine. Otherwise, I will frequently joke around and say, basically, if you don't, being as a dentist, if you don't really assess your case well, don't know where the teeth are going to be in the future, first establishing them back, regardless you use the machine or not, you only let the machine to correctly guide you to the wrong destination. That's because you did not establish the teeth properly. So basically, we utilize this machine solely to execute what we want in the future. And of course, the navigation machine did a good job. But there are a couple of critical factors to do the good work. So throughout this past 3-4 years, we have been 100% executed this digital workflow in every single of our patient and try to improve and modify our procedure up to the current status. This is the workflow and the procedure that we consider 100% safe for you, and that's why I introduced it today. So as I said, we want to have the future teeth, we want to have this combing CT, and we want to put these two together to overlap this so we can be able to plan our implant. That being said, you have to have the markers on your skin and on your design, and you have your markers on your combing CT. So you use these markers to overlapping all these two images. And this is what I'm going to introduce you guys right now. We use the bone tap, the mini implant, to execute this procedure, as well as a fiducial markers that we glue over the print out teeth prototype. As I introduced previously, we will always do the digital wax up. We will always try whether the wax up is correlated to your clinical scenario, whether it's correct or not, by verifying phonetic function. Then we will utilize this prototype to carry markers for us to overlapping your diagnostic wax up as well as your combing CT. So if you can see the yellow star, that is the marker sticking out in our prototype for us to superimpose combing CT as well as your diagnostic wax up design. For the green star is the bone tag that we stick inside the bone. Basically, we place it a week in advance so that it's not only for superimpose these two images, but most importantly, the green star will help us will be utilized throughout the surgery as a calibration landmarks. So this is very crucial. We need both of the yellow star and green star to execute the full digital workflow. And this is how, after we superimpose both of the image, you can see in the bottom, the middle section, we overlapping the pink prosthetic design along with the bone. Then we can be able to shift the angulation, position, depth of all the implants somewhat parallel to achieve the implant supported fixed dental prosthesis that's screw tenable. So after we plan on our implant position, then we will execute this procedure through dynamic approach. We will stabilize two different trackers, one on the patient, one on our tool. So wherever our head moves, basically the tracker can track your motion as well as the patient's motion, so we can be able to place the implant in exactly following by our plan. And the same plan, as I said, we will utilize it to fabricate, to prepare our provisional restoration that has the hole already that facilitate our pick-up procedures, the immediate loading procedure. So as you can see right now, after you plan on this implant position, the software can generate a standard file, the standard tessellation language file, for you to utilize to design your shell. But here, I'm gonna address a little bit more about how we should correct the angulation. Remember, I keep on saying, we want this provisional and also definitive to be screw tenable, full arch splinted. So this guide over here, basically, it's, if we follow the bone, you can see the screw axis is literally coming out through the labial, which is not screw tenable. So if you see the cross-section view, I'm gonna enlarge it over here. If following, I keep on saying, our implants supposed to be placed correlated to the teeth position. However, if the bone is significant atrophy, it's been destroyed or it's been restored for such a long time, the implant still needs to be placed within the bony confine. You literally cannot place the implant outside bony confine regardless you're urban or not. So you have to place the implant in somewhat within the bony confine, following by the position of your future teeth. Then you, at this point, the junction, if the missing positive disparity in between these two, that you cannot move your implant any further outside the bony confine, then you need to reconsider, okay, is there any way that I can modify my prosthetics, but still maintaining a screw tenable? And that falls into this critical part, which is the transmucosal abutment. The transmucosal abutment, it carries a couple features. Number one is it has to be angulation correctable. Number two is it has to have a certain color height for us to correcting this implant from the implant, the fixture platform to the abutment platform. So basically, regardless whether we are going to correct the angulation or not, you will see all this feature of the transmucosal abutment. It always comes with a dome shape. So I want to, and this is the part I want to elaborate more about especially the BEGO abutment, transmucosal abutment. But let's take a look first how we are going to design it in our software by considering the angulation correction, especially when the bone graft is just not achievable sometimes. So you can see the blue part is the transmucosal abutment that we're connecting on the implant after we have been deciding where the distribution of the implant is going to be. Then we will secondly adding on this blue part of the abutment. If you see down below in the middle, you will see the yellow part of the abutment. And that is the part where we turn the angle. We will first, if you see the pink column at the right part, we will first measure the angulation that's highly possibly that we want for the screw axis coming out through the cingulum at the anterior tooth to achieve screw retenable implant prosthesis. We first calculate that. It's roughly 20, so we put on 20, and that's also, the transmucosal abutment that BEGO provide. It's 20 and 30. It comes with different color height. So basically, we type in 20, the abutment will turn 20, and that is the part in the future. Once our transmucosal abutment has been adapted on, it will be able to turn from the cingulum that we can achieve screw retenable. So this is the part that I mentioned, regardless of whether the angulation has been changed or not, the abutment itself is dome shaped, so it allows the inter-implant angulation change up to 15 degrees each side. And on top of that, there is 20 and 30 collection, the 30 option. But always remember, the more of the angulation change, the more color height that you will need, as you can see through the pink area. But also remember, or also noted, that when you correct certain angulation, it's less, meaning when you're, for instance, you're correcting only for 20, and you're only designing for very minimal of the color height, you always will run into the problem that you have the less of the vertical restorative space that's required, but it ended up eating up more of your horizontal space, just like the blue arrow. So you always need to understand your transmucosal abutment thoroughly, so that you can be able to design and build in all the factors into consideration. So here you can see the titanium alloy, and this is why I love BEGO implant parts, because as a prosthodontist, you always want to know what the alloy is. Like, we're crazy about the alloy and the material that we use. So BEGO is pretty much like one of the very few that they've listed down everything on their package, being very standard on what they provide you. So you can see over here, for 0 degree, it comes with 1 and 3 color height. When the angulation it gets more, you have less selection of the color height, and as you can see just from the figure, that's because it requires more of the turn, and of course you need more of the space. So always keeping in mind that what your implant has in terms of providing this transmucosal abutment, along with the different diameter of the implant. So this is a summary of what I use. Like always, I always will remember in my brand that, okay, if I want to plan and invest the implant, by knowing that there is no wide platform of the transmucosal abutment for this particular system, then I couldn't be able to, plan an implant in. That's 5.5 millimeter wide platform diameter of the implant. I can only select whatever I have, considering the prosthetic part, and that is the main goal that I want to share with you guys. For the prosthetic screw, this particular brand is 15 Newton centimeter for the torque. And what I love about BEGO Implant System is also, again, they provide you literally is like one of the very few. They provide you actually 2 of the prosthetic screw in one packages. So they want you to use one in your laboratory work, but when you're literally delivering as for final, you always have another spare one to screw that in, instead of using the laboratory one that you have been like screw on and then screwing on like 20 million times. So this is how we correct it at the end. Remember, it used to be coming out over the labial of the crown. Now it came out from the cingulum. And this is how precise that we have planned and we have executed. You see like all the implants just being placed, and angulation just came right through the corresponding holes that we leave. For the last part, that is we will connect this shell with the abutment. So the way that we select our abutment is, the way how we select our abutment is, once the implant they're all in, we will measure clinically also the height of soft tissue again to see whether clinically that's reflecting to what our plan is. And we always provide the radiograph check after we inserted in all this implant, after we insert the implant, after we insert this transmucosal abutment, the multi-unit abutment, we verify the periapical film of the radiograph of the seating. Then we torque it in to the proper preload according to the recommendation of the manufacturer. And we will just also, if you're not continuing the procedure straight, we will then apply a healing cap over the abutment just to protect the soft tissue to carrying on to the following procedures, not jeopardizing the true abutment itself. So this is how, if you see the left side, this is the healing cap, how we adapt it on. If you're carrying on your procedure, this is the time you will start to connect your titanium tempered cylinder. And this is the parts that we chose. We will never use a plastic one because it's very difficult to sustain through 6 months period. We would always use the titanium abutment. And this is how we picked it up. And then we inserted it. For verifying it's screw tenable, it's full arch splinted. At the end, we always put it down. Wherever we activate it, it has to pass beyond, according to literature, 30 to 35 Newton centimeter in order to achieve proper primary stability. And the same thing, we'll execute it out as the bottom. And this is how we completed this case. So the clinical case, I'm going to walk through really quickly about how we literally plan on each case and execute it as the implant, as the immediate load procedure with the digital workflow. This is how we plan the ambulation change of the implant. The day of the surgery, we, again, on the patient, we will adapt on a GPS, a tracker, to start the dynamic approach. We place starting from posterior implant to the anterior immediate implant. We analyze our implant by verifying the angulation with our stent, because the stent is corresponding to your plan, right? Now I realized that there is an implant off, so I went back to the system to see what my surgeon has been doing, and this is what she has, this is what she did. She literally did not follow the plan. You can see the implant has been shipped to slightly to the palate. So that's why, you can see that particular implant is slightly towards the palate. However, we can still be able to achieve this path of insertion for a screw-retained splinted type of provisional, because we apply on this transmucosal abutment. Applying abutment, select proper height with measuring your with the measurement. Then you verify the radiograph, torque to its proper preload, and then you carry on to your immediate loading procedure by using the titanium abutment. You connect it on, and of course over here you need to enlarge your screw access hole, because it's no longer corresponding to your plan. Once you apply on your titanium temper cylinder, you always need to verify through the radiograph again whether each single one that's been properly seated. Then we can start the pickup procedure. You always need to conceal, you need to protect the screw access channel, because the last thing you will want is a drop of the autopolymerized PMMA dropped into the hole, and there's nothing you can do to remove everything. So this is what we did. Clinically, we pick everything up, and then whatever the holes or the up and down, the rocky part, down below all around, we will then fill it in with the autopolymerized PMMA. After we filled up all the gap, we then will trim away all the excess, all this excessive material, but making sure and being very cautiously not jeopardizing the platform of the implant, of the temper cylinder. Of course, over this procedure, you can always put on your laboratory analog over each side. So when you're trimming away all this excessive material, you wouldn't run into the problem of trimming away the platform of the titanium temper cylinder. At the end, you always want to highly polish. Basically, you just want to create the environment for the tissue to heal around nicely. So you want it to be highly polished, and you want it to be convex. So in the future, the patient could be able to clean it around. And then you do the final occlusal adjustment. This is how 1 month of the follow-up that's soft, we can see. For the last part, I want to finish up with the last 5 to 10 minutes. That's about the definitive prosthesis. So instead of we're using the hybrid original design that's introduced by Malone, nowadays we use mostly this type of unit build prosthesis. It provides a couple features. It provides a couple features. First, it's splinted. That's according to ACP protocol. It's splinted, it's screw retainable. However, the individual crown that's been fabricated by either zirconia or lithium disilicate that gives you not only aesthetics, but the best retrievability in the future. So for ancient time, if we want to do this hybrid, acrylic and denture teeth wrap around, throughout the time, the denture, the PMMA steel, it's compomer. It stinks because it has a lot of pores inside. So throughout the time, it accumulates plaque, it starts to become stent, and it has a door. And also it gets weaker because of how the mechanical property of PMMA, the hybrid material, the denture-based material. Over here nowadays, we don't want any type of headache, as I just mentioned. So we want wherever that has the problem, it does not accumulate bacteria. And also if it breaks, we can easily just put back another crown by ordering from the lab. So that's why this type of design is called unit build, has been really, it's been basically executed like 80% out of my practice. The rest of 20% is for the financial problem. We still need to provide them the hybrid design. But with this premium design, we literally can achieve not only cross-arch stability, the screw retenable work, as well as the cleansability, durability, and also retrievability in the future. So this is how we did after 6 months of the healing. You can see the soft tissue heals beautifully. And we tested out each of the implant by the tactile sensation as well as the radiograph. Then we will start to make an impression. We will take the impression with the open tray impression technique. Nowadays, in the current era, in 2021, now in winter, there are many articles mentioned about full arch scan, the full arch optical scanning implant solution that is promising in the future. However, achieving all this prosthesis that has screw retenable ability, but as well as passive fit, it still takes a lot of effort, especially we need to consider whether your implant numbers is limited, your implant numbers, your implant angulation, whether it's too off or not, the distribution, whether when we scan, it will introduce too much error from the soft tissue or not. And then also the technique you're using for scan, the impression coping, which is skin body you're using in your skin, as well as your scanner. So nowadays, in order to always execute the procedure with control, as I mentioned, the protocol that I introduced you, that has been executed 100% in my practice. Now, the impression as the last part, of course, I need to, be responsible to my private practice, the patient. So still, we use the conventional workflow. And the conventional workflow, the standard is we have to use the open tray impression technique because we want everything to hold together strongly. So we verify the seating of the impression coping, then we connect everything together. We will use the custom tray to take the impression utilizing this is the regular medium viscosity of the VPS material. We poured it up, use the artificial gingiva. Then we'll always verify this master cast, verify the accuracy of this master cast with the verification jig. So basically, we will fabricate a verification jig connected all back. Again, we picked up, put back our master cast, and the way that we verified it is this jig supposed to drop that just like that. Just drop it with one click, without rocking, without distortion. And that is, we approve this master cast. Then we will utilize our provisional to articulate the master cast, also sending the lab technician where the teeth that we designed originally. So they will send us back another set of the teeth arrangement with the minor correction that's from your provisional restoration. And also it has to achieve the occlusal scheme that you want to achieve in the future. And then you verified it clinically in the patient's mouth. Also verified it through the aesthetics. This is clinically, we will screw it in to verify the occlusion and also the aesthetics. We take the photos, make sure the patient is happy. And then we use this design to be the final outer shape of your tooth design. For the metal structure, we will just do the cutback equal proportionally of what the material you're using. If it's zirconia, you probably want to use maybe 1 millimeter. If it's resin, that's okay, maybe you want to use more, not only to provide the rigidity, as well as you want to hide those potentially, alloy reflection showing through your teeth. So this is the cutbacks, the same thing for mandible. So at this moment, then you will fabricate out a splinted type screwy 10 titanium alloy material type of the framework for you to try in. When you try in, we always follow the standard according to YUM, one screw technique. Verify the x-ray, see the seating. You can see all the seatings on top of the multi-unit abutment. It fits just 100% perfectly. With the radiograph preferable by wing. So the last part is easy. We fabricate this individual crown, cement it on. And the pink part, it's still, we cannot, there is not a better solution, but heat process composite nowadays. Of course, I understand there is a problem with the composite, but we're not so confident yet with the porcelain adding on to this titanium alloy or pure titanium framework. So we still need to elaborate the clean stability. We try to have the tissue adaptation only along with the titanium framework, but leaving the pink composite over the labial side for aesthetic purpose only. So this is how we acquire this teeth setup. Sorry, the definitive prosthesis. We always, before putting in the patient, but before the delivery, we verify the occlusion on the articulator. It's all screw tenable, and on the articulator, as I keep on addressing, I want it to be mutual protective occlusion. So we recorded down all the movement, and you, of course, you want to see how it reflected 100% in your patient's mouth. So the day of the delivery, after so much work, it's literally 30 minutes of the job. You clean up everything, you screw it in, it's supposed to fit perfectly, and you adjust the occlusion minorly. As we desire for anterior guidance, just exactly reflecting how you work on your articulator. So check upon our patient. As I mentioned, he kept saying like, don't block my eyes, I'll just let everybody know me. So he's so cute. He is super happy even during the provisional phase, because finally he doesn't need to leave with the removable, the valplast, the removable prosthesis. And for the final, you can see he's even more handsome. He also gained a lot of weight because of how the chewing ability has been improved. And he just couldn't be happier. You see how over here we use zirconia that's from Ivo Clark, that's called Prime. So we individually cemented down. It not only achieved aesthetics, the zirconia is smooth, it achieves biology premium quality, but also in the future, in case any one of those crown has problem, I can always order another one and just cement it back, but still remaining the full arch implant prosthesis that's screw tenable. So that comes to the last 20 seconds, which is the entire whole workflow that I literally designed a course, which is a 5 days consecutive course, 5 days, full day consecutive course for this 1 hour lecture. So I'm sorry for going through everything. That's pretty fast, probably not in depth enough, but this is how I have my course held up. You can see everybody will learn in the mornings through the didactic course, and then we'll practice through each steps how they supposed to execute it from design of your case, simulating your implant position, place the implant in, and do the immediate loading procedure. So that being said, I'm sorry that I passed beyond the time for 10 minutes. That being said, thank you. If you have any questions, now we're open to answering all the questions. Thank you.
Thank you so much, Dr. Kuo. So there are no questions at the moment, but some greetings from Terry Ngo. He writes, welcome to dentists from Vietnam and others. And I should say to you and to all the participants, greetings from Marcio. So he apologized for being not there because of internet problems. But we want to thank you for your time and your really interesting presentation. And we hope to see you soon, maybe next year. And we want to thank all of the participants for the support of our webinars. And we will do some more next year, but you was the last this year, and it was really great and really a pleasure. So thank you very much.
Fantastic. Okay, I'm sure you guys will have questions. If you have questions, let's say in the future, just please do email me, because the workflow that we have been executing, as I said, on almost like every single of our cases, we literally would love you guys to also start to work on your very first case. If you encounter any problem, always email me, because that's also the time for us, me and my team, to learn and grow. Thank you so much for your time, participating in this lecture, and, stay with me for an hour. And I hope to see you soon again.
Thank you.
All right, so have a nice day.
You too, thanks.
Thank
Bye.
you. Bye.